Good evening, everyone. We are standing between your dinner and today's concluding session. So, thank you so much, Dr. Maitri Madam and team ISHBT and IMA Nasik, including Dr. Siddesh, for this wonderful opportunity. So, we'll quickly run over the few cases and I'll try to wrap up as early as possible. So, I thank all the eminent panelists here for joining this discussion. So I think Dr. Madam has introduced all the panels. So brief about pancytopenia. I'm sure this is your experience in your clinical practice. About 2 to 5% of variable degrees of pancytopenia in your OP consultations. 1 to 3% of these are severe, might require hospitalization, and after exhaustive evaluation, 20% may remain idiopathic. So you have to essentially deal with cases of pancytopenia, no matter you are from surgery, medicine, OBGY, or any other medical fraternity. So to brief definition of pancytopenia, separation of all the 3 blood lineages. So most important aspect, I have come from another geographic pocket, Telangana, where certain etiologies are common, and I'm sure certain etiologies must be more peculiar to Nashik and surrounding region also. So, for example, if you look at the Western versus our Eastern literature, certain conditions like aplastic anemia, which is supposed to be rare in the Western hemisphere, are not so uncommon in our set of patients. So, before I start my cases, I'll request Dr. Shailesh sir to briefly discuss about the etiological classification of pancytopenia when you consider case presenting with pancytopenia.
As the classical teaching goes, whenever you have pancytopenia, it means either there is less production or more destruction, to be broadly specifying the etiology of pancytopenia. When you come to the less production, it could be either because of hypofunctioning of the marrow or it could be because of the infiltration of the marrow. So that is how you can broadly specify the different causes of pancytopenia. And then as per this category, you can go on for different reasons why this happens. For example, hypofunctioning could be because of aplasia of the marrow, or could be because of vitamin deficiencies. Infiltration could be because of malignancies, leukemias, even solid tumor malignancies are known to infiltrate the bone marrow. And as far as the destruction is concerned, it could be hypersplenism and any other cause which could lead to pancytopenia.
Thank you, sir. So with that brief introduction, let us quickly go through our cases. This is a 45-year young gentleman, symptomatic anemia in the form of generalized weakness. Also mentions tingling numbness of hands and feet, almost a month duration. History of anorexia leading to significant weight loss and associated with increased frequency of loose motions of the same duration. And this is his hemogram. You can see there is pancytopenia. MCV is high, 119 femtoliters. MCVH is relatively normal. RDW is high. So normally RDW by CV is 11 to 14. 26 is very high, and he has, for this degree of anemia, reticulocytopenia. So this is what a brief history and hemogram, which is kind of window of opportunity to peep into the possible etiologies underlying any hematological manifestations. So Dr. Ramakant sir, how will you approach this case, and what are your differentials based on the history and hemogram?
At the outset, I thank ISHBT for giving us this opportunity to interact with you all. As it is a triad by William Castle in Winthrop. This is a classical triad. There is neuritis and weakness and anorexia. So we have heard about RDW and macrocytosis. So RDW is high in iron deficiency anemia. Other than that, it will be in macrocytic anemia.
Yes.
So high RDW with macrocytosis and reticulocyte count, which is 0.5%, but corrected reticulocyte count here will be less than 0.2%.
Yes.
So it is a reticulocytopenia. There is no absolute reticulocyte count which is mentioned. So it is all fulfills the criteria of pancytopenia. But fortunately, this is a straightforward diagnosis of macrocytic anemia. Most likely it is B12 deficiency in context with all fortification of food, which is occurring in our country also, of folate fortification, iron fortification is there, and probably that is increasing the problem of B12 deficiency. So this is a clear-cut case of probably macrocytic megaloblastic anemia, probably because of B12 deficiency.
Thank you, sir. So as a simple rule of thumb for all the eminent clinicians in this august audience, any anemia, whether it is macrocytic anemia, high RDW, unless proved otherwise, it's most of the times nutritional anemia should be ruled out. So if MCV is less than 78, high RDW, first rule out iron deficiency, high MCV, high RDW, try to first rule out megaloblastic anemia. So nutritional anemias are common causes of high RDW, more so in a patient with reticulocytopenia, which confers hypoproliferative anemia, right? So this was his presentation, hyperpigmented knuckles, smooth red ball tongue, and this was the peripheral smear examination. And as sir has elaborated, it is a megaloblastic anemia. Remember, megaloblastic anemia is not always nutritional, so megaloblastic anemia is not a diagnosis in itself. You have to rule out the underlying causes. So, like a ECG for a cardiologist, endoscopies for gastroenterologist, and imaging for neurologist, for most hematological issues, interpretation of hemogram, and that's not just numerical values, but these histogram values, as Dr. Kunal has elaborated in his talk, can really give a clue in vast majority of hematological conditions. Now, coming to vitamin B12 deficiency associated megaloblastic anemia, this is a paper published about a decade back in JAMA. You can see in a proven megaloblastic anemia, vitamin B12 levels are haphazard. Majority of the patients have normal or more than normal B12 levels. So, normal B12 levels doesn't rule out megaloblastic anemia. So, Ramakant sir, so your take on this. So, how often do you see normal or more than normal B12 in a clinically strongly suspicious of megaloblastic anemia patient?
It is definitely a problem quite frequently occurring. We don't know whether it is really a normal B12 level or it is the injectable received at general practitioner level, and we get a normal B12 level more than 300 also. But if it is a clinically all picture of B12 deficiency is there, in these cases methylmalonic acid level, MMA level, or holotranscobalamin levels, and this, if it is available, but MMA will definitely tell us that even if this B12 which is normal, and if clinical picture is there, then it will definitely suggest you of B12 deficiency, and whether it is a haptocorrin bound or active B12. So active B12 is measured by holotranscobalamin, and along with that, more than that is MMA level available, which is at costing 700 to 2400. And that will definitely tell us whether it is a B12 deficiency or not. And unnecessarily, we will not be finding out the causes for megaloblastic anemia other than B12 deficiency, because it is very easily treatable. So these are the things which are, and we do find that B12 level is normal in clinically diagnosed microcytic anemias or B12 deficiency anemias.
Thank you, sir. So, as sir has elaborated, methylmalonic acid, which we not do routinely, but extremely high LDH can be another important supportive marker. LDH running in thousands. Barring hematological malignancies like lymphomas and ALL, you don't see such high LDH. So, absence of organomegaly and extremely high LDH is another marker which can really help us in suspecting megaloblastic anemia and a therapeutic trial of parenteral B12 supplements. And most of you from different streams of medicine, so subacute combined degeneration, presenting with neuropathy, alopecia, infertility, food drop, like these are some of the newer, not so uncommon presentation of megaloblastic anemia. Coming back to our case, as I mentioned you earlier, megaloblastic anemia not always nutritional. So in this case, anti-intrinsic factor antibody was found to be positive. So what are the implications? This is a pernicious anemia. They require lifelong parenteral B12 supplements because they won't be able to absorb B12 normally from their gut because of lack of this intrinsic factor. And they also need annual GI endoscopic surveillance because atrophic gastritis and GI malignancy is high in these cases. So like this cartoon, going to the root cause of megaloblastic anemia is essential, and not everything is nutritional. So useful tips: pancytopenia with jaundice. Many a times I get these megaloblastic anemia cases referred from gastroenterologist or these patients initially following up with gastroenterologist. So they present with jaundice because of ineffective erythropoiesis. So megaloblastic anemia and PNH are the two common etiologies of pancytopenia with jaundice, and pancytopenia with coagulopathy we will discuss later. So coming quickly, running over the second case, 39-year lady, again a short duration of symptomatic anemia, fever 2 weeks, bleeding from gums, nose, ecchymotic patches, menorrhagia, short duration, again 3 days, severe pancytopenia, but platelet count is 40,000 and the bleeding manifestations are disproportionate to the degree of thrombocytopenia. That was the reason why we did coagulation profile at diagnosis. PT, APTT sky high, fibrinogen extremely low. So Dr. Kunal, your take on this case?
So typically pancytopenia with this kind of a DIC-like profile happening, the first thing I would like to say is the peripheral smear. I'm very worried for the acute history to rule out an underlying APML straight away. It comes to mind basically because of the combination of the pancytopenia and the PT, APTT which you're showing. So that's the first thing I would like to see in this patient and then move on.
Yeah. So this was the bleeding profile disproportionate, explained by both thrombocytopenia and active DIC, and this was the peripheral smear.
So, classical abnormal promyelocytes which are seen, and there are some ore rods there. So, yeah. So once you have that, then you need a diagnosis which will be based on, typically the diagnostic is FISH for translocation 15-17. Two things to be kept in mind. From experience we see this. If it looks like APML, one, you can have APML variants. And when we ask for FISH for 15-17, it may not in the panel include the variant probes. So always ask for 15-17 and variants. Second, we always rely on the flow on 34DR negativity and say that this is abnormal promyelocytes. But NPM1 positive AMLs have the same phenotype. Third, if you see faggots and ore rods, and rarely if you have a 15-17 negative by FISH, there are 2 to 4% of APMLs which are FISH negative but RT-PCR positive. So that's where the pathologist and its confidence that, okay, this is definitely APML, and because we know the therapy is so important, going that extra step and getting the PCR also becomes very relevant. So
Thank you.
The three things.
So the one important message here is pancytopenia, abnormal white blood cells on the peripheral smear. Please involve hematologist or oncologist on an urgent basis because this is something related to hematological malignancies. So, Dr. Siddesh, urgent hematology referral for patients with pancytopenia.
I think APML is one where we have already discussed. Second is febrile neutropenia, DIC. Then again severe aplastic anemia, PNH with active hemolysis, because then there might be chance that kidneys might shut down. So in these cases, it's required. Also, there are certain metabolic emergencies like tumor lysis syndrome, wherein there can be seizure or there can be cardiac abnormalities. That is one thing. And second is Waldenstrom is one condition wherein there can be pancytopenia and there can be acute problems.
Yeah. Thank you so much. So, all the extreme severe pancytopenia, severe anemia, severe symptomatic thrombocytopenia, pancytopenia with febrile neutropenia, patient running high fevers, possibility of DIC, abnormal peripheral smear, possibility of HLH, and most important metabolic emergencies like symptomatic hypercalcemia, hyperkalemia, or evidence of tumor lysis syndrome in the form of AKI, hyperuricemia. These are the possibilities, these are the circumstances where there is possibility of underlying hematological malignancy, and there the hematology referral should be sought on an urgent basis. So this probably is my last case. This is a 26-year young gentleman, I'm sorry, I think, 26 years, young gentleman, symptomatic anemia requiring multiple transfusions, 3 weeks, mucocutaneous bleed on and off 2 weeks, and fever with productive cough and facial pain 1 week. And you see on the hemogram, severe pancytopenia, again MCV high, RDW normal, reticulocyte count 0. Shubham, your take on this case?
Thank you. So it is a young male with a history of 3 weeks, symptomatic and severe pancytopenia. The thing interesting in this case, the MCV is high, but RDW is on the lower side. So that means the cell size, RBC size are uniformly larger. So and retics is 0%. So there is almost no productions of the cells in the factory or bone marrow. So in this case, my first diagnosis would be hypoplastic or aplastic anemia. Second, I will go for the other investigations, and definitely this is an indication for bone marrow study.
So again, as thank you, Dr. Shubham. As Dr. Shubham elaborated, severe pancytopenia, as we discussed earlier, again, early, as much possible early hematology referral. And if you see on the differential count for a young, I think this was a female patient. So there is lymphocytic predominance. So based on this severe pancytopenia, we did bone marrow. This was the presentation. You can see a nasty fungal infection sitting on the bridge of the nose, oral thrush eroding lateral half of the tongue, extensive bleeding manifestations justified by severe profound thrombocytopenia. So all the 3 lineages, the patient is symptomatic and short duration. So based on severe pancytopenia, we did bone marrow. And if for the sake of understanding, I put a normal bone marrow picture on the upper one, and on the right lower, this patient's bone marrow completely empty, replaced by mostly by fat. So normal bone marrow cellularity, can be guessed by the simple formula 100 minus age. Younger the patient age, higher is the cellularity of the bone marrow, and more advanced is the age, lesser is the cellularity of the marrow. So for a young girl, this was definitely hypoplastic marrow. So this was a very severe aplastic anemia. On top of that, she has MDR E. coli sepsis. So essentially, she underwent bone marrow transplant, half-match bone marrow transplant with one of the parents. Unfortunately, she rejected the graft. She underwent second consecutive half-match transplant with mother as a donor. Now, almost 7 years post-transplant, she is completely cured and leading a normal life. So, upfront bone marrow studies for patients presenting with pancytopenia. Dr. Siddesh. So, first 2 cases, we didn't even thought of doing bone marrow. But third case, we did bone marrow right at first consult in the OPD.
One is peripheral smear gives us a lot of idea. So if there are any abnormal cells in peripheral smear, abnormal promyelocytes, or we do that. Second is if there is relative lymphocytosis, then again, and with normal RDW, I think that is pointing towards aplastic anemia. Again, there would consider. Only if there is clear-cut macrocytosis, anisopoikilocytosis, hypersegmented neutrophils are there. In these conditions, I would like to hold on marrow. And if there is a clear-cut hypersplenism documented in Doppler, or there is spleen with thrombus in it, I would still wait and watch and not do bone marrow.
Yeah. So as Dr. Siddesh has nicely elaborated, abnormal white blood series cells on the peripheral smear like blast, leukoerythroblastic picture that always signifies something is infiltrating the marrow, and extremes of pancytopenia or severe anemia associated with reticulocytopenia. These are the absolute indications of considering bone marrow in patients with and extremes of age. Bone marrow is mandatory. So I think can we take one more case, last one? Yeah. So this is a 74 years renowned surgeon from Gulbarga, presents with symptomatic transfusion-dependent anemia for 3 months. So he was loaded multiple courses of IV iron parenteral butyrol. It took 3 months for the physicians of Gulbarga to realize this is not simple nutritional anemia, and that was the time he was sent to hematologist. And on his examination, barring extreme pallor, the systemic examination was unremarkable, no organomegaly, no lymphadenopathy, and look at the hemogram. So I'll ask Dr. Kunal to elaborate on his hemogram, please.
So in the hemogram, there's a severe pancytopenia. The hemoglobin is very low. definite leukopenia with a WBC count of 2700. The neutrophil lymphocyte percentages are relatively maintained. So unlike the previous case of aplastic anemia, here the neutrophils are more. The MCV is high, that is 127. So you are thinking, is this a B12 deficiency anemia because the RDW is also high? Or second, is there any other cause of macrocytosis? Now, slightly chronic history, elderly gentleman, only pallor, no other complaints. Simply nutritional may not be the only answer, so I will have to keep in mind, the ideal way would be to supplement with B12, but this patient might be a candidate for doing marrow and cytogenetics to rule out a myelodysplastic syndrome. Again, a peripheral smear morphology for dysbiosis will be also very, very useful in such a scenario.
Yeah, thank you. So, as Dr. Kunal elaborated, B12 or megaloblastic anemia, therapeutic trial of B12 has been tried for him for 3 months without any improvement, and he continued to remain heavily transfusion dependent. And this was his peripheral smear. You can see, for the sake of understanding of the audience, I'll just elaborate. This is a upper one is a normal neutrophil, 2 to 3 nuclear lobes, but the lower one is an abnormal neutrophil, single nuclear lobe and abnormal granulation. There are some immature myeloid series cells, myelocytes, and possibly a blast on the peripheral smear. So this was circulating abnormal dyspoietic cells, and based on this we did a marrow. Again, the biggest cell in the bone marrow is megakaryocyte. Normal nucleus is like a popcorn like. Here it is multinucleated, definitely abnormal. So all the 3 series of all the 3 lineages on the bone marrow were abnormal. So this was a case of MDS, and if you remember, I put it his case, his hemogram, disproportionate anemia, WBC platelet was modestly suppressed. So this turned out to be MDS RA with 5q minus syndrome. So he was started on simple oral lenalidomide tablets, and he almost 3.5 years post diagnosis, he continues to enjoy a good health with hemoglobin hovering around 13 to 14, and he's back to his normal life, enjoying his surgeries at his hospital in Gulbarga. So this was a case of MDS. Again, pancytopenia in elderly, apart from nutritional megaloblastosis or nutritional anemias, 2 important differentials. One is hematological malignancies like leukemia, myeloma, and second is myelodysplastic syndrome should be considered. So I think there are many cases, but I will skip. I thank all the eminent panelists for their valuable inputs, and thank you ISHBT and IMA Nashik for this wonderful opportunity. Thank you.